Hello, welcome to chapters 7 and 8, the human body. Chapter 7 with chapter 8, kind of part of chapter 8 woven in the human body. Knowledge of the anatomy is necessary for everything you do as an EMT because it's based on your patient assessment. Every patient assessment is based on the idea that you're the patient's anatomy. Now, with that said, if you think about your patient laying down on their back and you're standing up at their head, your left arm is on the left side, your right arm's on the right side. When we're describing the patient's body, you're at the head and looking down at the patient, and you can remember left and right. If you were to walk down to the patient's feet and look towards their head, your left is their right, and your right is their left. With that said, your patient would be lying down on the cot, and when you're explaining something, you need to make sure that you are using their left and their right, not your right and left. And I know that sounds kind of goofy, but at 2:30, 3 o'clock in the morning, you've been woken up out of a deep sleep, and you have to be able to go from 0 to 100 miles an hour in a matter of seconds. The brain has to catch up a little bit to where you're looking at your patient and you're describing your patient in patient assessment to the receiving hospital. You've got to remember that you're using their right, their left. So you kind of have to change the way your brain is working. And the longer you're in this business, the easier it'll get. But every once in a while, you do have to stop and realize that, hey, I'm thinking my left, my right, and it's got to be the patient's right and the patient's left. The term anatomy is the study of the body's structure, and using accurate patient assessment allows us to locate body organs and systems. And the physiology of medicine, anatomy and physiology, is the study of the body's function. It also allows us to give quality patient care by knowing anatomy and physiology, remembering that we're talking about the patient's right and left, even though we're looking at them and their right is our left. We don't want to accidentally say, oh, it's on the left-hand side, but really the injury's on the patient's right-hand side. So you have to be able to convert back and forth. The body itself is made up of regions that we must be able to universally accept anatomical terms to describe directions and positions of the body. So we're going to talk about some anatomical terms. The anatomical position that we deal with every patient is the person standing, facing forward, palms facing forward, and this is a standard for all healthcare providers. So we need a good understanding of what is the anatomic position. Person standing, facing forward, palms facing forward, and this is standard for all healthcare providers across the world. Talk about some anatomic planes. The body is divided into planes to describe specific areas. We have a plane from top to bottom called the transverse or horizontal plane. This is the plane that splits the body from top to bottom. Think about it being split roughly at the umbilicus, the belly button, the medical term, the umbilicus, cutting the body in top to bottom. The term sagittal or median plane splits the body from right to left. The median, meaning the middle, going down through the middle of the body, and splits it from left to right, going down through between the eyes, through the nose, and splitting the body in half left to right. Then we can split the body another way, front to back, by using the frontal or corneal planes. This splits front and back. And these are used as anatomic reference points when we're describing where the injury is to the receiving hospital. Some other directional terms that we have is the median, the middle of the body. Think of the middle of the body being created by an imaginary line down through the center of the body, passing between the eyes and extending down past the umbilicus, known as the belly button or the navel. The term midline, splitting the body in half, midline. We have a term of medial, medial referring to a position closer to the midline. The midline being splitting the body left to right, medial closer towards the middle. As you can see in the picture, the medial towards the middle, medial towards the middle. The term lateral refers to a position further away from the midline. Lateral meaning away from the midline. The term bilateral. The term bilateral refers to both sides of anything. We have bilateral arms, we have right and left arms, we have bilateral legs, right and left legs, we have bilateral eyes. But where this comes into play, especially, is really when we're talking about injury patterns or breaths. We have bilateral lungs. We have a right lung, we have a left lung. When we're checking lung sounds, we want to hear the same identical sounds on the right side and the left side. And when we describe lung sounds, we can describe them as we have equal and bilateral breath sounds, meaning they're the same on both sides. It's easier to report that over the radio to the receiving hospital than it would be to say, well, the right side lungs sound clear and the left side lungs sound clear. The easiest way to say it is clear lungs bilaterally. The receiving hospital knows that that means right and left lungs are clear. Bilateral also we use if we have possible fractures of the femurs, the large bone in the upper leg. You can have two fractured femurs. It's easier to say bilateral femur fractures. It's just more professional to use the term bilateral fractures, bilateral breath sounds, than trying to say we have a fracture of the left leg femur and the fracture of the right leg femur. We also have a term of unilateral. We don't use it very often, but occasionally referring to one side, unilateral. The term midclavicular is the line that runs through the center of the clavicle, also known as the collarbone, and down through the nipple line below. Since there's two clavicles, there are two midclavicular lines. It's just an imaginary line, middle of the clavicle, straight down through the nipple line. That's considered midclavicular. The term proximal, meaning closer to the torso, proximal. The term distal means further away from the torso. The torso being the chest, the abdomen, minus arms and legs. That's known as the torso. The term palmar refers to the palm of the hand. We use that terminology when we're measuring possible burn, body surface burn area. Based on the patient's palm size, we can give an estimate of percentage of burn. We'll talk more about that when we get into burns. And then we have the term plantar, referring to the sole of the foot. Think of plantar fasciitis on the sole of the foot. Some other directional terms we have on the lateral plane is we have the mid-axillary line extending vertically from the mid-armpit, which is known as the axillary region or the axial, all the way down through the ankle. Mid-axillary line, once again, we can use that to split the front to the back. The term anterior, meaning front, posterior back. You can use the term ventral for the anterior portion. And if you think of ventral, think of the two lower fin of fish towards the belly. Those are known as ventral fins. And then the dorsal, the back side, which would be where the big fin is on the back of a fish, the dorsal fin. We use it for dorsal for the posterior part of the body. Also, think of the dorsal as the back side of the hand. You have the palm, and then the back side of the hand is known as the dorsal part of the hand. The term superior refers to above in up and down, and the inferior refers to below. And that's from a area, you have a designated point that you could say superior to the nipple line, meaning above the nipple line, inferior to the nipple line, inferior to the waist, superior to the waist, but inferior to the nipple line. Those are points of reference when you're trying to paint a picture to the receiving hospital. We have 4 quadrants in the abdomen, and these quadrants divide the abdominal area and where certain organs are located. The 4 quadrants are the right upper quadrant, RUQ, the left upper quadrant, LUQ, right lower quadrant, RLQ, and left lower quadrant, LLQ. Now those are 4 abbreviations that you would use when you're documenting finding something in the right upper quadrant, left upper quadrant. So when you're documenting, you can use shorthand, and that is known across the medical field, right upper quadrant, left upper quadrant, by using the abbreviation RUQ, LUQ. The torso, like I said, the trunk of the body is the body without the head and the extremities. So if you describe the trunk, it's the body without the head and no extremities. We have some positional terms that we need to know, and they're supine and prone. Supine, the patient's lying on their back, and prone, the patient is lying on their abdomen. And we use these positional terms when we come across our patient and we're documenting where we found them or how we found them. They were supine or they were prone. They may be in another position known as the recovery position, also known as the lateral recumbent position. The patient's lying on their side. The patient can be on their left side, and it's called the left lateral recumbent position. If they're on their right side, it's the right lateral recumbent position. We use this positioning of a patient if we have a patient that is possibly a stroke patient, somebody that may have is vomiting. We want them on their side because we don't want them to aspirate. And what we do, we may have to place them with their head on their arm and then their right arm coming across the front of their body, kind of in a tripod position to keep them in that recovery position or lateral recumbent position. For transportation, we use a position called Fowler's position, also known as position of comfort. Fowler's, it's a position where the patient is seated. The head of the stretcher is usually elevated to a 45 or 60 degree angle. And if the patient is leaning back slightly less than 45 degree angle, we might call it a semi-Fowler's position. And this position we use with our patients that are having difficulty breathing, having chest pain, severe chest pain. Somebody that's having difficulty breathing, it's very hard to lie down. So we put them in the Fowler's position, or better known nowadays as the position of comfort. That position of comfort, you go, well, how do I find that position of comfort? What you do is your patient's awake, alert, and conscious, talking to you. Now, they may have oxygen on them, but they can talk through the oxygen mask. You raise their head up and say, ma'am, sir, tell me when you are comfortable. And when they say, yeah, I like that position right there, then you put them in the position of comfort. They're having difficulty breathing. Most likely they're going to want to sit up. We have another position known as the Trendelenburg position or the shock position. This is when the patient is lying with the head slightly lower than the feet. Typically the feet or the whole backboard is elevated about 6 to 12 inches higher than the patient's head. This position is very controversial nowadays. It was very common just a couple of years ago. So now it's no longer recommended, but we can use this in the patient that has had a simple fainting spell. You have your grandmother, your grandfather, that sitting on the couch, a get together, and all of a sudden says they kind of feel weak and dizzy and they kind of fall over a little bit on the couch. It scares you, yes, but this is the person, the type of patient that we can put in this shock position, because we can lay them down, elevate their feet, and actually raise their blood pressure 20, 30, 40 points. So it does have its use, but it's very controversial. So you're only going to use the Trendelenburg position or shock position based on your local protocol. The big controversy is that people were using it on patients that had neck injuries and back injuries, and they were exacerbating the problem of the back injury. So nowadays, it's all based on your local protocol. Next, we're going to talk a little bit about the human body systems. To start with, the musculoskeletal system. I know this is kind of hard to see the bones of the body, but the ones that you really need to be concerned with are the skull, the spine, the cervical spine, the humerus, which is the large upper bone of the arm, the radius and ulna bones, which are the two bones of the lower arm. The radius bone is the bone that runs towards or on the side of the thumb. Think about the anatomical position: feet forward, standing up, facing forward, hands with the palms out. The radial bone is on the side of the thumbs. You have ribs, you have the sternum, then you have on the lower extremities, you have the pelvis, you also have the femurs, you have a right and left femur, and then you have the tibia and the fibula, the tibia being the larger of the two lower leg bones. And then we have the metatarsals, and then phalanges, fingers up in the fingers and toes, the phalanges. And we'll talk more about bones here, but those are the major bones that we need to be able to identify with and be able to, when we're talking to the hospital, say we have a possible fractured radius ulna or possible tibula fibula fracture or femur fracture. So those are the bones that we're most concerned with. Talk a little bit about our musculoskeletal system. The musculoskeletal system extends throughout the body. It gives the body shape, and it has three main functions: to give the body shape, to protect vital internal organs, and provide for body movement. Now think about it. If we didn't have a skeletal system, we'd just be basically kind of muscle and kind of be like a big giant blob. And we would have a tough time getting around if we didn't have the skeletal system. Because if we were just this big blob, it'd be okay on a hill. We could roll down the hill. The only problem is, our body being just a big blob, how are we going to get back up the hill? We're good going downhill, but we're no good going uphill. Or think about that blob trying to get across a carpeted area. So musculoskeletal system has a lot of importance to it. The skeleton itself consists of the skull, the spine, the ribs, the sternum, the shoulders, the upper extremities, the pelvis, and the lower extremities. The skeleton system interacts with muscles, ligaments, and tendons. Remember that ligaments connect bone to bone. The tendons connect muscle to bone. And there were times that I had to learn things, when you're going through EMT school for the first time, and you try to remember so much, and you go, okay, tendons, ligaments, one does one and one does the other. How do I figure that out? The way that I learned was tendons, muscle, tendon, bone, muscle to bone, MTB, is a good way, because if you can remember muscle, tendon, bone, then you know that the muscle is connected to bone through the tendons, which then the ligaments to connect bone to bone. Just a little way of trying to remember something. If it makes it any easier on you, you're more than welcome to use it. If not, you can find your way of trying to remember that at 3 or 4 o'clock in the morning. Next, we have the axial skeleton, the foundation on which the arms and legs attach. The axial skeleton includes the skull, the spinal column, and the thorax. Here we have the skull and facial bones. Skull, also known as the cranium. Skull is the bony structure of the head, and its job is to enclose and protect the brain. Looking at the skull and facial bones going down the left side, we have the zygoma, which is the cheekbone. The maxilla is the upper part of the jaw. The upper part of the jaw. We have the mandible, which is the lower part of the jaw. The lower part of the jaw is the only movable part of the jaw, but the maxilla and the mandible are considered part of the jaw. You have the upper jaw, the maxilla, you have the lower jaw, the mandible. We have the orbit, which is the bony structure around that houses the eye. If you put your finger up towards your eye, you can feel where that bone, where that orbit is, the bony structure that protects the eye. The nasal bone is the bone at the top of the nose. When people say they have a broken nose, they've actually broken that nasal. And you can just run your finger down from your bone, the bony structure of the nose, down to the soft cartilage area. It's probably about a ½ inch long or so. Next, we'll talk about some skull and facial bones. The cranium consists of the front of the skull, the frontal bone. The top is known as the parietal bone. The sides are known as the temporal bones and the sphenoid bones. And the back is known as the occipital area. There's a mastoid process, which is the notch behind the ear. Mastoid process can get damaged with a head injury. In the base of the skull, there is at the bottom, the base of the skull, which is the bottom, has a hole in it. That hole allows the spinal cord to exit the skull, and this is called the foramen magnum. F-O-R-A-M-E-N-M-A-G-N-U-M. Foramen magnum. Once again, the bones of the face include the mandible or jawbone, the maxilla or upper jaw, the nasal bones, which give support to the nose, the orbits, remember, is the bony area around the eye sockets, and the zygomatic bones or the zygomatic arches, which form our cheeks. Any of these bones can be broken. One of the things that is kind of an interesting little tidbit is the zygomatic bones. I'm sorry, not the zygomatic bones. The mandible bone, which is the movable bone of the jaw, is the strongest bone in the skull. It takes a hard hit to break that jaw right there, that mandible. But it's actually the strongest bone in the face. Here we have cross-section of the brain and brain stem. The brain consists of the cerebrum, which is the largest portion of the brain and is referred to as the gray matter. Pretty good reason why they call it the gray matter, because it's the color of the cerebrum in comparison to the white matter. Part of the brain's gray, part of the brain's white. So that's why we refer to it as the gray matter. Inside the skull, the brain has 3 layers covering it: the dura mater, the arachnoid membrane, and the pia mater. Easiest way to remember from inside to out: the dura mater, the arachnoid, the pia. Think of DAP or PAD, PAD, from inside out, from the outside in. DAP, inside out, PAD. The dura mater, arachnoid membrane, the pia mater, this is where your patients will develop bleeding within the brain. And that's how they identify what type of bleed it might be. Make a note that where the medulla oblongata is located, the medulla oblongata, what a great word. But it's probably one of the most important words in the whole human body. Now, granted, the heart, that's a pretty important word. But the medulla oblongata, the heart has a very important job to do, and that's to keep beating, to keep us alive, to help, circulate blood throughout the body. But the medulla oblongata controls breathing and heart rate. So if the medulla oblongata is damaged, it's going to affect the heartbeat and breathing. So It's pretty important. From the medulla oblongata, the spinal cord continues on down through the foramen magnum, down into the spinal column. The spinal cord goes into the spinal column. Spinal cord's only about 11 inches long, between 11 and 13 inches long. Then the rest of it breaks down into nerve endings. So the spinal column houses and protects the spinal cord and the cerebral spinal fluid. Cerebral spinal fluid is also called CSF, cerebral spinal fluid. This is what houses the spinal cord as well as gives a little protection around the brain up in the skull. The spinal column itself has 33 vertebrae. And if you look at the picture of the head, you can see that the head seems to be large and heavy. That average human adult male head weighs about 8 pounds. And that 8 pounds rests on a very slender neck. So a rear end collision can cause the head to fly forward, then whip back, fracturing the cervical vertebrae. That's why we're so protective of our high cervical injuries, because damage to that cervical spine injury area, we got to remember that the medulla oblongata runs through this area. Since it controls your breathing and heartbeat, a broken chunk of spine lacerating the spinal cord there at the medulla oblongata can be fatal to your patient. And I mean fatal like quickly fatal. So that medulla oblongata, it is not protected. It's right at the base of the skull. So part of it's inside the skull, part of it's outside the skull, leading down into the spinal column. So a laceration there is fatal to your patient. So we're going to place or think C-spine precautions to minimize this from happening. Without getting too far in depth in that, there's certain protocols that you'll follow, whether you put a collar on the patient or not put a C-collar on the patient any longer. The lumbar region is also injured by EMS providers because of improper lifting, and it's not supported by any other portions of the skeleton. Think about the lumbar. It supports the ribs and the thoracic spine and that 8-pound head on top of it, on those vertebrae of the lumbar region. So this table here for the spinal column, the cervical spine, the corresponding anatomy is the neck, and there's 7 vertebrae. The thoracic includes the thorax, the ribs, and the upper back. There's 12 thoracic vertebrae. The lumbar, which is the lower back, has 5 vertebrae. The sacral, which is the back wall of the pelvis, has 5 vertebrae. And the coccyx, also known as the tailboard, has 4. Now, one of the ways to remember how many vertebrae are where, and this is one of those things that if you need this to remember it for testing purposes, more power to you, good deal. If you don't want to use it to help remember that you have 7 cervical, 12 thorax, 5 lumbar, 5 sacral, and 4 coccyx. Okay, but a way that some may want to remember it is cervical 7, eat breakfast at 7. Thoracic 12, eat lunch at 12. Lumbar is 5, we eat supper at 5. The sacral is 5, fused into 1. And the coccyx, the tailbone, has 4. Breakfast at 7, lunch at 12, dinner at 5, 5 fused into 1, and 4 for the tailbone, for the end. The back wall of the pelvis with 5, and it's fused together. That's what's holding our pelvis together. That sacral, where the 5 are fused into 1. There's 5 vertebrae there fused into 1 to make 5. Here we have a picture of the cervical spine. Recall that the medulla oblongata runs through the cervical spine area. And since it controls your breathing and heartbeat, a broken chunk of spine lacerating the spinal cord here can be fatal to your patient. So we've got to think of placing C-spine precautions to minimize this from happening. The lumbar region, remember, is also injured by a lot of EMS personnel because of improper lifting, and it's not supported by any other portions of the skeleton. And it's supporting the ribs, the thoracic area, the head, and in that thoracic area, think of all the internal organs that are in there that the lumbar is also supporting. And most of the time in the fire service, it's not when you hurt your back. It's not if you're going to hurt your back, it's when you're going to hurt your back. It's not something you try to do, but it can happen. Talk about the thoracic cage. The thoracic cage is also known as the chest area. It surrounds and protects the contents of the thoracic cavity, which includes the heart, the lungs, and major blood vessels. It has 12 ribs that attach posteriorly to the thoracic spine. 10 of those ribs, 10 of the 12 ribs, attach anteriorly to the sternum, also known as the breastbone. And the other 2 are called floating ribs. So we have a total of 12 ribs each side that attach posteriorly to the thoracic spine. 10 of those ribs attach anteriorly to the sternum, which leaves us 2 ribs called floating ribs. Ribs are also known as costals, C-O-S-T-A-L-S, costals. Ribs are also called costals. So there's a space between each rib or costal. So the space between the two ribs is known as the intercostal space. The intercostal muscles between the ribs assist us in breathing by moving the ribs up and down with our respiratory. The sternum is divided into three sections. The manubrium is the superior portion. The body is known as the middle section, and the xiphoid process is the inferior tip of the breastbone. The pelvic girdle, or the pelvis, commonly referred to as the hips. The pelvis contains bones that are fused together. The ilium, which is the superior bone that contains the iliac crest, which is the bony wings, felt near the waistline. It also consists of the ischium, which is the inferior posterior of the pelvis, the inside of the posterior of the pelvis. The pubis is formed by joining the bones of the anterior pubis, and then the sacrum. The sacrum is a portion of the spine, but it makes up the posterior pelvis. Talk a little bit about the appendicular skeleton. That includes the arms, legs, their connection points, and the pelvis. So the appendicular skeleton includes the upper extremities, the pelvis, and the lower extremities. The lower extremities, the large thigh bone of the lower extremity is known as the femur, which connects the lower leg, consisting of the tibula and fibula. Sitting on the anterior knee joint is the patella, also known as the kneecap. The tibia is the medial bone in the lower leg and the larger of the bones in the lower leg, and it sits medial. So it's the inner side of the bone, inside. The ankle connects the tibia and the fibula to the foot. The lateral meniscus, the lower end of the fibula, and the medial meniscus is the lower end of the tibia, are the protrusions of the ankle. The ankle itself consists of the tarsal bones. The foot bones are the metatarsals. The calcaneus, C-A-L-C-A-N-E-U-S, is the heel bone itself, and the phalanges are the toes. The upper extremities, when we perform our patient assessment, the clavicle itself is usually palpated as part of our thorax exam. And that'll make more sense when we go over the patient assessment sheet when we're doing medical and trauma patient assessment. However, the clavicle, scapula, and humerus make up the shoulder girdle itself. The clavicle, the scapula, and the humerus make up the shoulder girdle. The clavicle or the collarbone is located anteriorly, and the scapula is located posterior. The arconium process is the highest portion of the scapula and felt just behind the distal end of the collarbone. Between the shoulder and the elbow is the humerus. Then we have our elbow joint, which allows us to flex. Then we have the radius and ulna. And remembering the anatomic position, the radius is the lateral bone, the ulna is the medial bone. The radial pulse is taken over the radial bone, and it is aligned with the thumb. And that's why it's easier to remember that radial to the thumb when we think of the anatomic position. We get our pulse on the radial side. The wrists consist of carpal bones, and these are the bones of the hand are the metacarpals, and the fingers are the phalanges. We have some different types of bones. There's 4 types of bones in the body. We have irregular bones, such as we would find in the vertebrae. We have long bones, such as the humerus and the femur. We have flat bones, such as the ribs. We have another irregular bone would be like the scapula. And then we have short bones known as the phalanges. We also have ball and socket joints. The ball and socket joints, this is where the femur fits into the acetabulum to form the hip joint. It's where the ball goes up. The ball of the femur goes up into the acetabulum to form the hip joint. And then we have a hinge joint in the elbows. Joints themselves are formed when bones connect to bones. And what connects bone to bone? Ligaments. And what connects muscle to bone? Tendons. MTB. This is the end of part 1 of 4 parts of the human body. So if you have questions over part 1, go ahead, email me dcollins@dccccd.edu, and we'll set up for part 2 of 4.